Good evening, all the aspirants and dear Asif sir. We will start our session now. So today we have Mega Mock Test Debriefing Live class, and the speaker we have here is Dr. Asif Iqbal, who is the HOD in Respiratory Critical Care and ECMO Services in Apollo Multi Speciality Hospital, Kolkata. Thank you, sir. So you may start now. All the aspirants, you can unmute your mic and communicate with sir.
So, how many of you have given the mock test? Mohammed Irfan has given, John Chakao has given. From this month onward, every month I will give you a 50 question mock test with different system, and I will take the debriefing session. And it is my request to all of you that please give your mock test. Unless you are giving the mock test, you will not able to understand your preparation. So please give mock test. Okay. So now coming to the today I will discuss about the gastro. There is a 23 question in the gastro mock test. And Sana, I will request you give me slot this week, another slot to discuss about the renal question, and those who have not given exam yet, and please give the exam. So, hello, Sana.
Yes, I am here.
Yeah. So
Okay,
you
so
will
I'll.
give me another slot where I will
Okay.
discuss about the nephrology, renal system.
Sure, sir.
In how many of you are appearing exam this year in May, in April? Students. So those who are appear in this year, this April, I have a good news for them that we are organizing this immerse EDIC crash course where there will be more than 100 question, 200 question for exam, and there will be a 2-day debriefing session where you will get revision from the all covering the all the domain and including all major and minor domain. So please communicate with Sana regarding your registration on the crash course, and we will do in the March. So just before your exam, you will get freshen up knowledge and revision of the all the domain. And the gastro and the nephro is a very important domain. There are five major domain where the maximum question come. One is your respiratory, second is your cardiac, third is your gastro, and fourth is your neuro, and fifth is your renal. Then also question come from the other system like musculoskeletal system, scoring, and general the electrolytes area, the SOC. But this major chunk of question coming from this five area. So you have to know the important subdomain also. So during the crash course, we will discuss all about the subdomain and what type of question you might get in your exam. So now start 68-year-old lady is admitted with intensive care unit. 68-year-old lady is admitted to the intensive care unit following acute respiratory distress. She has past medical history of hypertension, type 2 diabetes mellitus. I've given all long stem question intentionally because the most nowadays in EDIC long stem question is coming, and it is very important that time management. Okay. So type 2 diabetes, chronic kidney disease, stage 3, he current medication include metformin 100 milligram, sorry, 1000 milligram, amlodipine 10 milligram, ramipril, aspirin. Upon examination, he has a blood pressure 158 by 92, heart rate is 112 per minute, respiratory rate 28 beat per minute, temperature is 100 degree Fahrenheit, oxygen saturation 89% on room air. She report progressive dysphagia and past 3 months, particularly with solid food, and has lost 8 kg of weight. And the blood report showing that the white cell count is 12.8, more or less same, only the albumin, more or less the normal range, only albumin is 2.8, and his EGFR is reduced 42. Serum creatinine is little high. On urgent upper endoscopy revealed 4.2 centimeter distal esophageal mass and luminal narrowing. Biopsy confirmed the moderately differentiated adenocarcinoma on invasive into the mucosa muscularis propria. The whole body PET scan showing that FDG update in distal esophageal mass, no significant lymphadenopathy, no distance metastasis, cardiac evaluation show preserved left ventricular function, ejection fraction is 55%. Which one of the following statement regarding the neoadjuvant therapy is most accurate for this lady? So usually in the previous EDIC exam, we are not getting direct question from the chemotherapy, but nowadays the question is coming on the chemotherapy. So, so the option given here is perioperative radiotherapy combined chemotherapy demonstrated superior survival outcome. So there are four options. One is the perioperative radiotherapy combined with chemotherapy demonstrates superior survival outcome compared to chemotherapy alone. And post-operative chemotherapy is associated with higher risk of esophageal perforation. No. Perioperative concurrent chemoradiation significantly increase postoperative mortality? No. Perioperative chemotherapy alone provide equivalent survival benefit to combined chemotherapy? Is also no. Preoperative chemotherapy should be avoided in patient with renal impairment? Usually no. There are sometime when the mass size is very high, preoperative chemotherapy will help to reduce the mass and which help in operation. So in this case, perioperative radiotherapy in combined with chemotherapy demonstrates survival outcome compared to only chemotherapy, because the why radiotherapy and chemotherapy is important in the esophageal mass. One is the drug penetration, and second is radiotherapy penetration is very good in esophageal carcinoma. So now coming to next question, that is 62-year-old gentleman is admitted in intensive care unit, acute upper gastrointestinal bleeding. He has a part medical history, triple vessel coronary artery disease, 3 drug-eluting stent placed 8 months ago, Barrett esophageal disease is there, paroxysmal atrial fibrillation, type 2 diabetes mellitus. His current medication include aspirin 75 milligram once daily, clopidogrel 75 milligram once daily, metoprolol 50 milligram twice daily, ramipril 5 milligram once daily, atorvastatin 40 milligram once daily, metformin 1000 milligram twice daily. These are the medication. Now, your examination showing that 92 by 58 is the BP, heart rate is tachycardic, respiratory rate high, breath per minute, temperature 98.6 degree Fahrenheit, oxygen saturation in 2-liter nasal cannula 94%. So there is a GI bleed with past history of Barrett disease with multiple comorbidity, patient admitted with a shock, and the hemoglobin is 8.2, white blood cell count is normal, near normal, platelet count also normal, INR is 1.1, troponin T is little higher side, creatinine is near normal, high normal, lactate is little high. So after stabilization, gentleman undergoes surveillance upper endoscopy and which reveal 1.2 centimeter flat plaque of Barrett segment. Endoscopic ultrasound show the lesion confirm mucosa without lymphadenopathy, multiple biopsy confirm low-grade dysplasia, and variety of two expert gastrointestinal pathologists verified by two expert gastrointestinal pathologists. So which one of the following represent the most appropriate next step management of gentleman Barrett lesion? So immediate uh, transhilar esophagectomy with lymph node dissection, yes or no? Probably no, because already in the question it is said that there is no lymphadenopathy. Annual endoscopy surveillance 4-quadrant biopsy at 1 centimeter interval is the correct answer. Why this correct answer? I will explain. Urgent photodynamic therapy with porphyrin sodium. No. Neoadjuvant chemotherapy followed by surgical resection. No. And endoscopic mucosal resection, radiofrequency ablation. No, because the this Barrett esophagus with low grade dysplasia is not that the carcinogenic transformation. If there is a high grade dysplasia, then there is a chance of uh, progress to adenocarcinoma. So when there is a anything, any polyp or Barrett with a low grade dysplasia, your treatment will be go for the surveillance, and yearly you have to do endoscopy, and you can take biopsy if the size has increased. So that's why it is the second one is the answer. And neoadjuvant chemotherapy followed by surgical resection. This is depend upon when it is changes in the carcinoma. Now coming to 63 years old lady is admitted to intensive care unit with acute hemodynamic instability on post-operative data following elective thyroidectomy for observation and further management. Her past medical history include chronic obstructive pulmonary disease and 40 pack per smoking history, osteoarthritis, hypertension, and also Barrett esophagus is there. She underwent surveillance endoscopy 18 months ago, which shows no dysplasia. His current medication include aspirin, ramipril, amlodipine, paracetamol, and naproxen 500 milligram twice daily for osteoarthritis pain. The lady had resumed her regular medication 24 hours post-operatively. Her vital sign, her vital signs showing blood pressure is low, heart rate is high, 122 beat per minute, respiratory rate 24 beat per minute, temperature 100, oxygen saturation 94% room air. She appear pale, diaphoretic and confused. Glasgow Coma Scale 14 by 15. Surgical incision are clean. Surgical incision are clean with minimal serious Sarah's discharge, central venous pressure 4 mm Hg. She has received 2 liter balanced crystalloid solution, and the report showing the low hemoglobin, WBC count is high, INR is normal, activated APTT is also normal, serum creatinine is high normal, serum lactate is high, metabolic acidosis is there, base excess minus 62. So next is the lady subsequently developed large volume of hemostasis and her blood pressure dropped to 65 by 35 mmHg despite ongoing fluid resuscitation. Packed red cell transfusion has been initiated. So which one of the following most appropriate next step of management? Here the option given, the continuous aggressive fluid resuscitation, PRVC transfusion treating hemoglobin more than 10. Why it is not tried? Because already you have given the fluid resuscitation. In spite of that, the blood pressure dropped to 65 by 35. So you have to do something else. Urgent upper gastrointestinal endoscopy following initial resuscitation. So it is the guideline says that when there is a active bleeding, upper GI bleed, if you have the endoscopy therapy, then the treatment is first you initial resuscitation with the fluid, and once it is stabilized, then you have to stop the bleeding by doing endoscopy. So if you able to do here, the problem is the hemorrhagic shock. So the bleed due to the upper GI bleed. So that's why endoscopy after resuscitation is the correct answer. Emergency computed tomography, angiography of the abdomen, pelvis, arterial, venous space. Why it is not the correct answer? Though we also practice this. If you are not able to identify the bleeding vessel from the endoscopy, then you can do the this CT angio, okay, this computed tomography angiography to find out the culprit vessel, and then you have to do the radiologically embolization of this culprit artery, or immediate intervention radiological consultation. And for empiric angioembolization is not a correct answer. Emergency exploratory laparotomy is not always exploratory laparotomy for the upper GI bleed. Administration high dose of proton pump inhibitor and continuous supportive care. High dose proton pump inhibitor indicated in ulcer bleeding, but there is no role on the variceal bleeding. And if you see the causes of the upper GI bleeding, most commonly it is due to variceal bleeding. So that's why here endoscopy is the first choice of treatment if you have these facilities. Now coming to 59-year-old gentleman is admitted to intensive care unit, acute respiratory failure requiring non-invasive ventilator following community acquired pneumonia. His past medical history include insulin dependent diabetes mellitus, hypertension, generalized anxiety disorder, stage 2 chronic kidney disease. His current medication include insulin glargine 42 units subcutaneous once daily, and also insulin apart 8 to 12 units subcutaneously with meal, clonidine orally twice daily initiate 3 weeks ago, ramipril, amlodipine, and also for his anxiety disorder, estalopram 20 milligram orally daily. On day 5 of admission, he developed significant abdominal distension and epigastric tenderness. He reports progressive nausea and had 4 episodes of non-bilious emesis for last 4 hours. His vital signs show blood pressure 142 by 88 and heart rate is 92 beat per minute, respiratory rate 24 beat per minute, and temperature is a little high. The oxygen saturation 2 liter nasal cannula 94%. Physical examination revealed distended abdomen with moderate epigastric tenderness but no gargling and rebound tenderness. Bowel sound are present but diminished. And the laboratory investigation is 138 sodium normal, potassium 4.2 okay, chloride also okay, bicarbonate, urea nitrogen okay, creatinine little high, glucose is very high, and white blood count is normal. Serum lipase is near normal, and procalcitonin is 0.8. So what you are dealing? The computer tomography of the abdomen contrasts show markedly distended stomach, retained food particle, but no evidence of mechanical obstruction. And upper endoscopy revealed retained gastric content, no mucosal lesion, and mechanical obstruction. Gastric emptying significantly demonstrated. So just tell me what problem this gentleman suffer from. In this particular cases, what is the exact problem? So here problem is that this problem has this gastroparesis. This is due to diabetic. So those patients who are suffering for the diabetes, they have this is very common problem that they will tell you that low appetite. If they take a food once, then there is no thrust for appetite. So it is a gastroparesis, which is more common in a diabetic patient and where the gastric motility is decreased. So you have to give the you have to increase the motility diet. But most important thing also you need to have dietary modification. Small frequent meal, continuous less than 350 kilocalorie each, low fat diet, high fiber content, avoid carbonated beverage which can worsen the gastric distension, and consuming liquid between rather than the during meal. This is the treatment. And then second treatment is this is obviously this is the question of nutrition. When the similar scenario they will give, and they will tell you that patient on the rice tube feeding shows is stomach distended and content 200 residual volume. What next best step you will do? So just a minute. হ্যাঁ বলো। হুম। ওনাদেরকে বলো হচ্ছে আশিক বলে একজন আছে ওখানে, ওই নাইট ম্যানেজার, আজকে নাইট বেড ম্যানেজার। হ্যাঁ, আশিককে আমার নাম করতে, তাহলে হচ্ছে যে ও বলে দেবে। হ্যাঁ, আশিক, আশিক বাওয়ালি ওর নাম। So Uh, so there is a ESPN guideline. You do not stop the feeding when the patient not tolerating the enteral feed. So in that case, you have to do fast. You have to increase the motility by giving the erythromycin is the answer. But when it is due to the gastroparesis and patient is complaining of abdominal distension, then you have to give the you have to fast do the dietary modification. Now coming to question number 5th. 53-year-old gentleman present to emergency department with progressive upper abdominal pain over 4 weeks that become excruciating 6 hours prior to presentation. His past medical history include essential hypertension. So emergency department with upper abdominal pain and has a hypertensive, sorry, The hypertensive, smoker, type 2 diabetes. He had a bariatric surgery performed 5 years ago with morbid obesity. He developed post-operative gastroparesis following surgery, which resolved after 6 months. And he take Remipril 5 milligram once daily, metformin 1000 milligram twice daily, aspirin 75 milligram once daily. On examination, he appeared severely unwell, diaphoretic, and confused. His vital signs, so temperature is 101 degree Fahrenheit, heart rate 128, blood pressure is low 85 by 45, respiratory rate 28 beat per minute, oxygen saturation 96%. So patient in a shock. His abdomen is rigid, diffuse tenderness, involuntary guarding. The bowel sound are absent. There is no visible surgical site infection with his previous laparoscopic port. So abdominal pain with distension and shock. White blood cell count is 22,000. Serum procalcitonin 12. So there is a chance of you are dealing with an infective patient. And sodium, potassium is little lower side. Chloride is normal. Bicarbonate is low, so metabolic acidosis is there. Creatinine is little higher. Plasma glucose is little high. Lactate is high. So this is more towards the abdominal sepsis kind of scenario we are dealing with. So blood culture has been obtained. Broad spectrum antibiotic piperacillin tazobactam given. Uh, Computed CT scan abdomen, intravenous contrast reveal moderate free fluid in upper abdomen with fat standing around the gastroduodenal anastomosis and small amount of free air near left upper quadrant, and there is a mild wall thickening of the gastric pouch adjacent inflammatory chain. So so which one of the following most appropriate definitive management strategy for this gentleman in this scenario? So we are dealing with the abdominal sepsis and the CT showing that there is a fluid collection and air fluid correction near the upper quadrant. So there might be a uh, case of perforation. So in the option given here, urgent diagnostic laparoscopy with conversion on open laparoscopy if needed, emergency endoscopy evaluation with potential clip placement, intensive care admission, hemodynamic optimized, followed by interval surgery, computed tomography, percutaneous drainage of free fluid, and conservative management of nasogastric diffusion, serial abdominal examination. The answer is diagnostic laparoscopy with conversion to laparotomy if needed. Why this is the your appropriate answer? Because the patient has previous history of surgery and the pain abdomen with air fluid gas is revealed that there is a perforation or it might be new perforation or it might be the anastomotic leak. When in surviving sepsis guideline, when there is a sepsis, you have to do the source control. And if the bowel perforation is there, the indication is first open up the bowel and do prevent the anastomotic leakage. Then, or if the perforation, you have to prevent the leak. Otherwise, you can't control the sepsis. That's why the urgent diagnostic laparoscopy with conversion open laparotomy, if needed, is the correct answer. Now coming to 71-year-old lady presented emergency department with severe lower abdominal pain, fever, past 48 hours. Her first medical history include hypertension, atrial fibrillation, chronic obstructive pulmonary disease with on observation require hospitalization in the past year and no diverticular disease. Her current medication include Epic 7 5 milligram twice daily, bisoprolol 2.5 milligram once daily, ramipril 5 milligram once daily, and salbutamol inhaler as needed. He undergo emergency laparotomy to perform sigmoid diverticulitis in generalized fecal peritonitis. The procedure includes sigmoid colectomy, end colostomy formation, Hartmann pouch, and she is admitted intensive care unit post-operatively. Is commenced with piperacillin tazobactam, and every 8 hourly metronidazole along with his and heart temperature is little high, mild temperature is there, blood pressure is okay, noradrenaline required very minimum, heart rate is 92 beat per minute, respiratory rate is 18 beat per minute, oxygen saturation is 96%, 2 liter, nasal cannula post-operative day 2 is went with vasopressor and started on clear liquid. By post-operative day 4, she developed progressive abdominal distension with intermittent vomiting, absence stoma output for last 24 hours, and her stoma appear pink and viable but edematous. Recent laboratory data showing the count is okay, a little high. Hemoglobin is 10.2 is low. Platelet count is okay. Serum sodium, potassium is little lower side. Bicarbonate still okay. Creatinine is normal. CRP is little higher side. And serum procalcitonin. So you are dealing with some infection and related to obstruction. The abdominal excess of multiple dilated loop of small bowel air fluid level, no free interperitoneal air. So there is an intestinal obstruction. The colostomy is visible with small amount of gas in proximal bowel. Which one of the following represent most appropriate next step of management? So nasogastric tube placement with cessation of oral intake is the correct answer. So let's see the option. The urgent CT scan abdomen, oral and intravenous contrast, nasogastric tube placement to cessation of oral intake, administration of intravenous metoclopramide 8 hourly, ondansetron 6 hourly, emergency return of theater of additionalysis, glycerin suppository via stoma, gentle stomach irrigation, and upper gastrointestinal endoscopy rule out the mechanical obstruction. So, usually in this scenario, we do CT fast, but the when you go the step by step in intestinal obstruction, first thing you have to do the uh, nasogastric tube placement, then decompensation, then you go for CT scan, then you go for, if needed, the surgery. So here the question has given the appropriate next step of management. That's why nasogastric tube placement is the correct answer. And post-operative ileus temporary impairment of the gastrointestinal motility with commonly occur following abdominal surgery, particular case of peritoneal contamination. So in that case, fecal peritonitis was there. And nasogastric decompression severe multiple purpose. It provide the symptomatic relief, prevent aspiration, allow accurate measurement of gastric losses, and facility of bowel rest. This intervention combine appropriate fluid and electrolyte management from and the electrolyte management is very important in the ileus cases. So next question. 77-year-old gentleman present progressive abdominal distension, severe cramping pain past 24 hours. His past medical history include triple vessel coronary artery disease CABG done 2 weeks ago, complicated by post-operative atrial fibrillation, chronic lumbar spondylitis, type 2 diabetes mellitus, and hypertension is there. His current medication include aspirin, bisoprolol, amiodarone, metformin, oxycodone, and his temperature is little high, blood pressure is maintaining, heart rate is tachycardia, respiratory rate 22, breath per minute, oxygen saturation 94 room air, his abdomen markedly distended, tympanic and percussion means gaseous abdomen, and tender in left lower quadrant without peritoneal shine, bowel sound are high pitch and trickling. So WBC count is high and potassium is low and your bicarbonate is okay, serum creatinine is okay, C-reactive protein high, troponin I is normal, lactate is little higher side. So what you are dealing? You are dealing with infection. So this is the X-ray abdomen, demonstrate the marked dilated sigmoid colon, inverted U configuration extending into right upper quadrant, which is absent rectal gas imaging. So which of the following represent most appropriate next step management? Initiate intravenous neostigmine, urgent flexible sigmoidoscopy, attempt endoscopic decompression, CT abdomen pelvis, immediate surgical consultation, nasogastric tube placement, serial abdominal examination, empiric oral vancomycin, suspected Clostridium difficile, administration of polyethylene glycol solution via nasogastric tube. So there is a huge distension of the sigmoid colon. So correct answer is you do CCT and immediate surgical consultation. So this gentleman X-ray suggests sigmoid volvulus characterized by coffee bean sign. The sign is called coffee bean sign, while plain radiography is suggestive and computer CT imaging is crucial for several reasons. It confirms the diagnosis of higher sensitivity, identify the potential complications such as bowel ischemia and perforation, rule out the alternative diagnosis, provide crucial anatomical information for surgical planning. Patient's tachycardia, elevated white cell count, and lactate rise, concern of potential bowel compromise, making urgent evaluation essential. Following option can rule out for reason discussed below. Now coming to your question number 8, I will provide all the question and answer in a PDF format in your the mock test given in the LMS. So you will get the detailed explanation, other option also. Because of shortage of time, I'm going little rush because we have to complete 23 question. 68-year-old gentleman is transferred from district hospital with content rupture of abdominal aortic aneurysm. His past medical history include type 2 diabetes, peripheral neuropathy, hypertension, left hemicolectomy for stage 2 colon cancer 10 years ago, chronic kidney disease stage 2. His current medication include metformin, glyclazide, ramipril, amlodipine. Just a minute. Yeah. So amlodipine. Then on arrival, his temperature 98 degree. Just a minute. So temperature is 98 degree. Hmm. So temperature is 98 degree. Oh, sorry. His temperature 98 degree. The blood pressure is 82 by 48. So the heart rate is high, respiratory rate is 24 beat per minute, oxygen saturation 94 in room air. He undergo emergency endovascular aneurysm repair and under general anesthesia. Procedure is technically successful and deployment of a bifurcated endograft. Post-operatively, he transferred to surgical intensive care unit requiring noradrenaline to maintain mean arterial pressure more than 65. 14-hour post-operative post-procedure, he develops severe diffuse abdominal pain with marked distension. His temperature 101 degree Fahrenheit, blood pressure again low, noradrenaline requirement has increased, heart rate is high, respiratory rate 26, oxygen saturation 92%, and his urine output decreased to 12 ml per hour over past 4 hours. So recent investigation is sorry. Your WBC count is high, hemoglobin, serum sodium, potassium, everything is normal. Bicarbonate is low, so metabolic acidosis is there. Burn is high, creatinine is high, CPK also little higher side, lactate is high, base excess -6, pH is 7.32, so metabolic acidosis with lactate with patient is in shock. So what might be the cause of this scenario? Anyone can volunteer. Why this has happened?
Abdominal compartment syndrome.
So you are telling it is due to abdominal compartment syndrome. Okay, abdominal compartment syndrome might have this type of problem. Any other opinion from anyone else? Let's see. The bedside ultrasound show no free fluid in the peritoneal cavity. Hemoglobin remains stable compared to immediate postoperative. Which of the following most likely cause of his clinical deterioration? Uh, it is due to mesenteric ischemic and colonic compromise in abdominal compartment syndrome. What happened in abdominal compartment syndrome is the next best answer is abdominal compartment syndrome. So it is usually common when the patient getting large volume of fluid resuscitation, acute pancreatitis or abdominal surgery. Here the patient has aneurysmal surgery. But in abdominal compartment syndrome, the normal abdominal pressure is 5 to 7 mmH2O. When it increase more than 15, 12 to 15, then it's called mild, moderate, and severe. Mild is 12 to 15, 15 to 20 is moderate, more than 20 is severe. And first sign in the abdominal compartment syndrome is decreased urine output, and second abdominal distension, and third sign is you will get the compromisation lactate high, but blood pressure compromisation is the last stage. Here is you see that the hypovolemia is there, and also lactate is getting very high, and metabolic acidosis is there along with the urine output low. So lactate one of the marker of your bowel ischemia. And second important thing why it is commonest in this scenario, because when you are doing the aortic aneurysm, surgery, there is a chance of inferior mesenteric artery flow reduce. So it is the commonest complication after abdominal aortic surgery is ischemia in the bowel. And let's see what about the abdominal compartment syndrome. While abdominal compartment syndrome can occur following rupture of abdominal aortic aneurysm repair, particularly in massive fluid resuscitation, retroperitoneal hematoma, and gentlemen relatively modest fluid requirement and stable hemoglobin make less likely. Additionally, the fever and leukocytosis are not typical feature of abdominal compartment syndrome. Yeah. Now coming to this thing, 58-year-old lady is admitted to surgical intensive care unit, 3 days history of severe cramped abdominal pain, bloody diarrhea, persistent vomiting. Her past medical history include ulcerative colitis, diagnosed 6 weeks ago, currently sulfasalazine 1000 milligram, along with mesalamine 4 milligram bedtime, and also this patient suffering for hypertension, for that getting the ramipril and recurrent urinary tract infection. She completed 7-day course of ciprofloxacin, complicated urinary tract infection 10 days ago. She also report chronic knee arthritis, for which is taken naproxen 500 milligram twice daily. On examination, she appeared toxic with blood pressure is low, heart rate is 128 beat per minute, respiratory rate 24 breath, and temperature is high, oxygen saturation room air 94%, her abdomen distended, diffuse tender, voluntary guarding but no rebound tenderness, bowel sound are decreased, digital rectal examination reveal loose bloody stool. So hemoglobin is low, total count again high, mainly neutrophilic, potassium low, bicarbonate low, creatinine is normal, albumin is low, CRP is 185. So pain, bloody diarrhea, and persistent vomiting. Now coming to the computed tomography, abdominal and pelvis intravenous contrast demonstrate that colon dilated 7.2 and transverse colon diffuse wall thickness, pericolic fat standing, patent mesenteric vessel. There is no sign of perforation or pneumatosis intestinalis. Which of the following investigations should prioritize before initiating definitive medical management? So here the flexible sigmoidoscopy, mesenteric vessel CT scan, quantitative serum, cytomegalovirus, polymerase chain reaction, stool culture, microscopic ova cyst, and Clostridium difficile. So here you see that patient having surgical ICU, and for 3-day history of severe this cramp and bloody diarrhea 10 to 12 weeks daily, persistent vomiting, and patient was on ulcerative colitis. So it is not typical history for a patient who having the diarrhea and Clostridium difficile. Usually when you will get question Clostridium difficile, usually you will get question like patient having diarrhea after broad spectrum antibiotic. So after broad spectrum antibiotic, if you get this type of history, then it is correctly that Clostridium difficile. But in this case, why flexible sigmoidoscopy with mucosal biopsy is not correct answer, because already there is a diagnosis of Crohn's disease, and mesenteric vessel computed tomography, why it is not the correct answer, because you can do the CCT to rule out the cause of abdominal distension, but when there is a diarrhea in ICU, in critical care exam, you have to think first about the Clostridium difficile. So there is a pattern of question in EDIC examination. The pattern is that when the patient in ICU and talking about the diarrhea, so you have to think about two things. One is the osmotic, whether the patient is getting is due to osmotic diarrhea or not. If the question related to nutrition, you can think about the osmotic diuresis or osmotic diarrhea, or in infective angle if the infection is there. So usually if they give the broad spectrum antibiotic, sure shot you will dealing with the Clostridium difficile, or otherwise more commonly when in critical care exam, the diarrhea, bloody diarrhea especially, is Clostridium difficile. So you have to read all about the Clostridium difficile. The Clostridium difficile is a uh, this infection is opportunistic infection. Normally, when the patient get fluoroquinolone and get broad spectrum antibiotic, followed they this type of patient may suffer for the Clostridium difficile. Already patient has got ciprofloxacin in antibiotic 7 days course for his complicated UTI, and that's why it is more toward the Clostridium difficile. And the Clostridium difficile toxin, there is a two toxin, toxin A and B, and usually diagnosed by your either through the toxin or PCR technology. The PCR is more accurate, and you will get uh, correctly and highly sensitive and specificity. And second thing, the treatment, there might come about the treatment option of the Clostridium difficile. So treatment, you remember that metronidazole and the vancomycin, oral metronidazole is the drug of choice. And if the patient is not tolerate oral drugs, then you have to give the IV metrogyl, because IV vancomycin do not penetrate in the gut. So next question is 51-year-old gentleman transferred to intensive care unit from the emergency department, 3-day history of progressive jaundice, right upper quadrant pain and confusion. His past medical history, type 2 diabetes mellitus. For that, he's getting metformin, hypertension for that Remipil and amlodipine. And also he has a chronic kidney disease and underwent emergency laparoscopic cholecystectomy 2 weeks ago with acute calculus cholecystitis. Gentlemen deny alcohol consumption but admit regular with Brufen. On examination, his blood pressure is low. Heart rate is uh, Heart rate is 98, respiratory rate is 22 beats per minute, temperature 99, oxygen saturation 96% on room air, and he appear ecteric with mild peripheral edema, jugular venous pressure not elevated, central venous pressure measured by internal jugular catheter, 5 mm Hg, abdominal examination revealed right upper quadrant tenderness without peritonitis, laboratory investigation 11.2 white cell count, 12,000 platelet count, 142 serum aspartate amino transfer is AST and ALT is elevated. Serum bilirubin is 4.8. INR is little high. Creatinine normal. Lactate is also in the normal range. Troponin also normal range. So what problem we are dealing with? Progressive jaundice, upper quadrant pain, confusion, and there is a low BP, normal temperature. So And central venous jugular catheter is 5. So CVP is not very raised with abdominal upper quadrant tenderness and peritonitis is there. So let's see. So which one of the following likely etiology of liver dysfunction in clinical scenario? HELP syndrome, portal vein thrombosis, acute viral hepatitis, ischemic hepatitis, drug-induced liver disease, and autoimmunohepatitis. Why this is not HELP syndrome? Because HELP syndrome has a typical history. Usually, it is happen when the HELP syndrome is come. It is related to your young female pregnant lady. Why it is not portal vein thrombosis? Because there is no history suggestive of chronic liver disease. Why not acute viral hepatitis? Because there is no history of fever. And is why it is ischemic hepatitis? Because there is a blood pressure is low and the liver enzyme is high. So that is one of the marker or keyword of for your ischemic hepatitis, and the WBC count also is normal. Drug-induced liver injury. Why not is the drug-induced liver injury? Because drug-induced liver injury is related to the NSAID, metformin cause hepatotoxicity, but it is there is no hypotension is there, and autoimmunohepatitis is remain possible for new diagnosis with recent physiological test surgery, presence of confusion, jaundice, and also the low BP is not compatible with autoimmunohepatitis.
Excuse me, Dr.
Yes.
Asif.
Yeah.
It looks as if you misunderstood the question. They are saying which one is the least likely to be responsible for the patient's presentation. Look at the question again.
Okay. Which one of the following is the least likely etiology? So they are giving that they are giving the ischemic hepatitis is the least likely, but the scenario which what they have given answer, ischemic hepatitis shock liver is least likely diagnosis in this scenario. Several compelling reasons based on both pathophysiology and clinical presentation. Diagnosis ischemic hepatitis typically require three key elements. Clinical is systemic hypoperfusion, dramatic but transient increase aminotransferase level, typically 20 times upper limit of normal, and exclusion of other potential cause of acute liver injury. Acha. But here you see that the liver enzyme high, patient is in the shock, but what is the scenario? Uh, Scenario is given the BP is low, heart rate is high, and there is a tenderness without peritonitis. That is okay. But why they are saying that this is less? Yeah, let me check.
Seems like it is normal. That's why
No, how you say that this is a HELP syndrome? HELP syndrome typically occur in pregnant female, so there might be the answer has some defect. I will say why, because see why it is not likely HELP syndrome, because there is patient is 51-year-old, and here the answer is given the HELP syndrome typically occur pregnant female in third trimester. So here there is no not given clue. And portal vein thrombosis also, this means visible diagnosis, even recent abdominal surgery, laparoscopic cholecystitis is no which is known risk factor. Portal vein thrombosis can be elevated aminotransferase, lactate, not exclusive. Okay, I can't understand the portal vein thrombosis because of recent surgery. Acute viral hepatitis can be here, but in viral hepatitis, you will not see the how many viral hepatitis we found that patient having the shock, the BP is lower side, and drug-induced hepatitis can be happen because there is a the for knee pain the patient is getting the NSAID, and also patient for diabetes metformin, this is okay. And but regarding the autoimmunohepatitis, they're saying that due to physiological stress of surgery and presence of confusion and confusion is related to hepatic encephalopathy. So any type of hepatitis you might have because of high ammonia, jaundice pattern aminotransfer compatible with autoimmune. I think this question has some problem. I will go through again and I will check and I will reply on. Okay.
Okay, thank you.
Usually in your critical care exam, you will get scenario of hepatitis, and this type of scenario either you will get on HELP syndrome or in a ischemic liver disease. Uh, I don't know. I have to check once because this question is not typically look like a. We can't ignore the ischemic liver disease. Though we in ischemic liver disease, the SGOT, SGPT is very high, more than 2000, more than 3000. Here, that is not that much. That is only one negative point on the ischemic liver. Let's see. So coming to our next question, 61-year-old lady admitted with intensive care unit, 2 days history of fever, diffuse abdominal pain and progressive confusion. Her past medical history include childhood class B cirrhosis secondary to primary biliary cholangitis requiring 3 therapeutic paracentesis in past 6 months. He also type 2 diabetes mellitus managed with metformin, glycoside, hypothyroidism, levothyroxine, and she has completed 5 days course of oral amoxicillin daily last week for dental infection. On examination, her blood pressure is low, heart rate is high, respiratory 24, temperature 101, oxygen saturation 94% on the room here. Lady appear confused, glucose coma scoring is 14/15, abdominal rivet, diffuse tenderness. Just a minute. Diffuse tenderness. হ্যাঁ আমি একটা ক্লাসে আছি, আমি ফ্রি হয়ে ফোন করছি। Shifting dullness, positive fluid thrill, and there is a bilateral ankle edema. Laboratory data is showing hemoglobin low, WBC count is high, platelet low, INR is little higher side, low sodium, creatinine is a little high, total bilirubin is high, serum albumin is low, serum lactate is little high. So patient with fever, diffuse abdominal pain, progressive confusion. So what is your take up to until this value? You are getting scenario and value. The low BP, pain abdomen, confusion in a CLD patient. So diagnostic paracentesis revealed cloudy fluid, and following this result, neutrophil count 450, gram negative bacillus present, Albumin 0.8, total protein 1.2, following the most appropriate next step of management. So you are dealing with?
Peritonitis.
Yes. So spontaneous bacterial peritonitis, because neutrophil count is more than 50. What is the limit? The neutrophil count. If it is more than 250, then so the question might come on the criteria of diagnosis of spontaneous bacterial peritonitis. One is the neutrophil count, other is the albumin ratio between the fluid and your serum albumin. And obviously here given the gram-negative bacillus. Another type of question you might get, what will be the commonest organism for this infection? So that's the thing. And okay. So 12 question. Probably after this question, I will finish today's class because I have a chamber. I have to see my patient also. So Fatma,
Yes, sir.
Padma is there. So can you give me class tomorrow at 3 p.m. to 4 p.m. where I can conclude my next questions?
Yes, sir.
Like
Yes, sir. It's possible.
23 or 25 question total we have in the gastro. So I will complete by tomorrow. So it's okay na 3 p.m. to 4 p.m.
Yes,
online?
sir. Yes,
No,
sir. Yes,
the
sir.
student has to stay na. I know you are okay, I'm okay. Our student. So it is okay for all of you to conclude question tomorrow.
Yes,
Hello.
we'll be able to join. Yeah.
Okay. So now this is the last question. 64-year-old gentleman admitted in the intensive care unit with massive hematemesis. His past medical history include alcoholic liver cirrhosis, type 2 diabetes mellitus, atrial fibrillation, and also patients taken the diuretics. Probably they have a heart failure also, and no, the diuresis for his ascites management. On initial presentation, his blood pressure is 82/45. So low BP, heart rate 118 beat per minute, respiratory rate 24 beat per minute, temperature 97, oxygen saturation is 92%, 4 liter via nasal cannula. After fluid resuscitation, 1 unit packed red cell and urgent endoscopy reveal grade 3 esophageal varices with active bleeding, red well sign. 5 band are successfully placed. Octeroid infusion started, and his blood pressure dropped again despite fluid resuscitation. His hemoglobin remains 6.8. So no, there is no further bleeding there. Despite giving 3 unit blood, so bleeding, I think, still continuing. Platelet count low, INR is very high, fibrinogen is low, serum creatinine is little high, bilirubin high, albumin low, lactate is very high, and metabolic acidosis. So what they are asking, which one of the following most effective additional therapeutic intervention in this scenario? So you have given the CLD patient, you have given there is a variceal bleeding, you are given the medical management with octeroid. So the option increase octeroid infusion, transtubular therapy, intrahepatic photosystemic shunt tips, administration phase frozen plasma, repeat endoscopy for additional band ligation, injection of Singstaken Blackmore tube, and permissive hypotension strategy. So which one of the following is the most effective additional therapeutic intervention in this scenario? So because it is the tips is answer because they are asking most effective additional therapy. Otherwise, when there is a this type of scenario, if next best step, you have to optimize also by giving the your fresh frozen plasma and platelet, because the platelet count is low in a bleeding patient. You have to keep the platelet more than 50,000 and the fibrinogen level is 185. So there will be a problem in the clot formation and insertion of taken black mode tube. Usually, you will get a question variceal bleeding where you are not able to performing endoscopy. Then their answer will be saying taken black mode tube. It is previously it was very famous question from the GI regarding the insertion of taken black mode tube, and they also ask about the parts of this tube. So please go through this taken black mode tube and its indication and how you will place it, because it's also asked in the practical exam. So what is the commonest complication of tips? Anyone can give. John, commonest problem or complication?
Hepatic
Tips?
encephalopathy.
Yes.
I don't know, sir.
Hepatic encephalopathy.
Very good. Hepatic encephalopathy. Recently, we have one patient who has a CLD and done tips. After that, the patient went home and patient admitted with severe comatose situation with hypotension, and we found that ammonia level is 560. So it's very commonest complication of hepatic encephalopathy because it is bypassing the liver. So ammonia metabolism is hampered. So this patient having the hepatic encephalopathy very common. Thank you, dear. Tomorrow we will meet at 3 o'clock Indian time, IST. Conclude here. Thank you.
Okay, sir. We'll have a class tomorrow. Thank you, all the aspirants present here. Thank you, sir.